I think the first step is consensus. I think that's the first thing that we would want to do. We already have the data. The data on measurable residual disease has been published. There's even a meta-analysis published in JAMA Oncology not too long ago. The data is there. We already know this is prognostic. We already know this is relevant. I think the next steps are codifying it. And it sounds fairly simple and very straightforward. It's more complicated. But codifying, what do we believe a CR is? What do we believe a PR is? Do we still want to even adhere to those terms? Is a PR relevant? I think that has to be the first fundamental step. It can be a simple amendment to the current CHESN guidelines, or alternatively, it could be a new set of guidelines that are developed. What I would love to see over the next 1 to 2 years, because you asked how will these evolve over time, I think we have to learn to layer in some of the molecular biology, meaning an MRD negative state in the setting of a high-risk genetic mutation like P53, for example, may not carry the same weight. And as we think about response definitions, taking into account that inherent biological risk may be something that we have to think about. That is far more complicated. Like I said, we're not even at the point today, I would argue, where we're uniformly screening for CRLF2 rearrangements, for P53 mutations, and and the like. And so if, again, we have to get there step by step. I think the other thing that could come from this, as we're bringing novel agents into the space, again, a very nice discussion about nelarabine, but we could actually talk about rationing the use of selected agents for patients who have measurable residual disease, whether it be blinatumomab, whether it be nelarabine. And again, this is something that we're trying to do in the context of cooperative group studies. But it would be very interesting to be able to say, you have this genetic mutation, you have this amount of measurable residual disease, this is the therapy that would be best suited to get you into a remission, and then potentially also develop the role of bone marrow transplant. What I'm saying may sound very far-fetched, but I would ask you to just step back and ask, well, how do you think about Philadelphia-positive leukemia? Because that's exactly what we've done. It is high-dose chemotherapy plus a TKI, often with a consideration of allogeneic stem cell transplant on the back end as consolidation to improve the likelihood of cure. So we already have a model that we can build this on. And in Philadelphia chromosome-positive leukemias, again, we already have a model for MRD that's been well established by using those quantitative PCR transcripts for the BCR-ABL level, again, to help drive some of that decision-making.